Dr. Maldonado, we're back, man. We did a podcast a few months ago that was on elbow pain. Today we're going to talk more about the Achilles, the plantar fascia, some stuff. I think it's something that's seen quite common in my practice as well as in your practice, and I think there's a lot of like misunderstanding around foot Achilles pain, plantar fascia pain. So I think our goal today is just kind of clear up some of that misunderstanding. And just allow people to understand, the biomechanics of the foot, some anatomy of the foot, what some imaging looks like of the foot, and then, hopefully people have a better understanding of how we treat these things and how we can manage some of that pain there too. So, thanks for being back.
No, thanks for the invitation. I want to kick in. We're starting with the anatomy of those structures, and again, we're focusing on foot and ankle, but with the structures that are Achilles and plantar fascia. So Achilles is the strongest tendon in the body, and is comes in the leg all the way from, actually, if we think it's a connection of the gastroc have the medial and lateral gastroc, and it just connect with the Achilles, and the Achilles in the front have another muscle that is called soleus. So all that complex is part of this muscle activation. And then it just insert on the bony prominence of the heel or calcaneus. That's when it comes from north to south, but also on the plantar side where we put all our weight is where we have the plantar fascia, that there is another soft tissue. We can think about tendon and muscle, and is where the weight-bearing forces are. There are other part of the ankle, the joint, the bone, the cartilage. Today we are not going to talk in detail on that, but they are very important in the biomechanics and in the kind of injury. So those are the basic things that we need to know about the anatomy.
Yeah, I mean, ultimately the foot is super complex, right? There's lots of different muscle attachments. There's small, bony, bony anatomy in the foot too, and just the overall biomechanics of the foot is very complex too, just with walking, gait pattern. So, that's something that we can maybe brush on when we get to the biomechanics portion. One thing I want to start with is, how often do you see like sudden Achilles or heel pain that isn't a tear? So, somebody comes in and maybe they've exceeded the tolerance of that tissue. How often is that presenting to your office as opposed to a full-on rupture or tear?
So that's very interesting. So it's not common to have the acuity of ruptures. Ruptures is basically an acute injury. This happen more an unplanned movement where overstretch the fibers of the Achilles mainly is what we see torn. Tennis player or runners that they are doing ballistic movement. Those are not very common. However, the other population, which is extremely common, are the ones that come here and are more with chronic pain, that have been struggling with pain for a while. They come here and they are already 3 months in and say, I don't know what to do. This is not going away. And that's the magic that we have with our diagnostic tools and treatment tools to work on them.
Yeah, so I think, when you're doing your history, a lot of people will say, like, my pain didn't start that day. Maybe I had some tension in the lower leg. Maybe the calf felt tight, and then I started to exceed some of my tolerance. So I started to spike in running, or I'm training for a marathon, and the training intensity went up a little bit higher. And all of a sudden, I start to feel this discomfort, this pain start to settle in, and then it just continues to occur. It becomes something that maybe happens for 3 or 4 weeks and it just hasn't gone away. I feel like that's usually some of the
So I was preparing for this meeting. I went and get an article from NIH, and it's 2023. And some of the extrinsic factors, they say, is mechanical overload. There is constant effort, inadequate equipment, obesity, some kind of medication like corticosteroid, anabolic steroid, fluoroquinolones, which is an antibiotic that can cause calcification of the tendon. There is also improper footwear, insufficient warming or stretching hard training surfaces, and that's why we want the rubber kind of track is way better, and direct trauma. So those are factors that potentiate this problem.
So that patient comes into your office, you've gone through your exam, doing some palpation, you do some imaging. What are some things that you look for on imaging, that helps you roll in these diagnoses?
Basically, physical examination tell you like 90%, but there is always good, like when you look into literature, it said you don't need necessarily an imaging, but you want to know the prognosis and severity so you know how to approach the treatment. So for example, if you do a lateral view, an AP view of the calcaneus or ankle, you will see on some patient calcification the insertion of the Achilles tendon into the calcaneus, and that is telling you and can prove a point, hey, this is chronic, and we're not going to get rid of the calcification, but we can treat other things, and it can tell you like almost how long had this been going on. Also, for the plantar fascia will be a spur. The problem is not the spur. The spur is a consequence that have been building up for years. We will treat the plantar fascia. That's for X-ray. MRI, you can do it and then see the details of the texture of the tendon. That also is telling us that it's a chronic problem. There are studies here trying to check the fibers at a cellular level, and actually they don't find inflammation. They find chronic changes. I call that scarring, but there are many names for this. But basically, it's an accumulation of different cells that are not healthy on that tissue, and those are behaving as almost like a partial tear. So the arrangement of these fibers is not working the right way, so it's working more in an uneven way.
Yeah.
I do an ultrasound evaluation, so that is also a diagnostic tool that helps us to tell you the severity as well. It's very easy, it's very dynamic, and cheaper.
So like you said, that we can see on imaging where that tissue or the collagen has become slightly disorganized, right? It shows you there's been some kind of tendinopathy or repetitive stress or irritation of that tendon over a period of time. When these people come in and they're dealing with this type of condition, when do injections help and when are they not necessarily advised for?
So to tell you the truth, steroid injection, I'm not a fan for Achilles. I think it's too much of a tension tendon, and steroid, I always say, is to patch the pain, not to heal. And that can degenerate the tendon even more. So I don't do steroid injection to the Achilles. To the plantar fascia, I do it, and I explain to the patient that I don't want any ballistic movement or a high impact for a while. Other type of injection is what I do, that is PRP. It's more successful for the plantar fascia than the Achilles, but still there is enough successful rate that is worth it to do it. And now on is coming up to do an adjunct with other therapies, which is have been very popular lately, at the shockwave. Shockwave, I was researching, and it's keep coming. Shockwave is a very good adjunct.
Yeah, I mean, for me, that's my go-to with plantar fasciitis, is even Achilles tendinopathy, is shockwave therapy, right? Obviously, I'm non-invasive. The goal with it, and we've talked about this before, is just to help reorganize that disorganization of that collagen. So increasing blood flow, it sends those shock waves or sound waves deeper into the tissue, which helps increase blood flow to that tissue, which helps create reorganization over a period of time. But we can't neglect the the building capacity back for that tissue, right? So we can do all these types of treatments, these modalities, but if we're not building back strength and capacity for these tissues, at some point it's going to recycle back to pain and discomfort, because we never really fix the root cause of it just by doing the modalities. When you have somebody that comes in and injections, is obviously, like you said, it's going to patch the discomfort. It's going to give them some temporary relief. I think that's indicated for somebody who, is a week out from running a marathon and all of a sudden has foot pain, right? We want to try to get them through that marathon. Am I correct on that? Is that something that's like, if we can get this person through this event and then really get to the root cause or spend more time with trying to increase the capacity of that.
So that's a good point. So sometimes I can consider doing the plantar fascia maybe 2 weeks before the high competitive level. Achilles, I won't do it.
Yeah.
The key is correction of what is going on. If it's the footwear, if it's some inserts, and basically here said eccentric stretching will help achieve at least 40% of pain reduction.
Yeah.
So we have a lot of semi-invasive or invasive treatment like a shock wave and injection. That's more when you are not in the acute on chronic problem. It will be down the road. In the beginning, we need to just focus on the mechanics and the strengthening and stretching.
Yeah, I mean, I like that talking about mechanics. If we zoom out from this, a little bit, a lot of times we think of just the area of pain as being the area that we need to treat, right? Like this person comes in saying, I'm having plantar fascia, some Achilles tendinopathy pain. A lot of times we'll just rush to that area. If we zoom out a little bit, sometimes this is just a bigger, biomechanical system overload where that area is taking on too much stress because of poor biomechanics elsewhere. So, I think one area to look at, and we should always look at this area, especially with people who are dealing with foot and ankle pain, is how's the hip functioning, right? Is there weakness in the hip? Is there some type of possible like Trendelenburg sign where we're getting a little bit of weakness of the glute medius causing some increased internal rotation of the hip, internal rotation of the tibia, some pronation of the foot, right? So all those things, I think it's important that we zoom out and make sure we're looking at the full biomechanics and how this person is functioning within their activity to make sure we're not missing the point. And that's like, once again, we're not just recycling back to this pain in a few weeks once they get back into that activity. How often are you seeing people that have dealt with Achilles pain and plantar fascia pain at different times? Does one precede the other, or does it happen together?
They come in different times of life, but they are so mechanical, meaning on position that are standing for a long time, those that are obese, those one that they are sedentary and then suddenly they go for a trip and they come back, they are like, oh my God, what happened? That was slowly building up there for years, but then something trigger, and then that can go even for a year. So you need to seek medical treatment to reduce that. You don't want to suffer for a year. If we can take care of that in 2 weeks or a month, that's a win-win. Another thing that I want to make a point is the location of the, specifically the Achilles. There is, we classify into the insertional and non-insertional. There is, insertional is when the tendon anchored to the bone. Often we see some calcification there. And for some reason, that calcification can be painful. I have a lot of patients asking me why I got that calcification. I try to explain, I look in the literature and it looked like random, but in my mind, I think some of us, when we have an injury, even if it's chronic, slowly when we're healing, we can try to overheal, and that calcific lesion is part of that overhealing. Instead of scarring, it make it even harder. And that is very stiff, and that's what these stretching exercises are important. And also the shock wave to just hit that calcification and get it out of that insertional portion. However, when we go a little bit higher of that bone insertion, there is the non-insertional Achilles tendinopathy. That is usually related to the poor vascularity of the tendon. And it's nothing that you do wrong. It's just that the tendon, when you get injured, the vessels there are not helping. It just takes longer, and by taking longer, it accumulates that scar tissue. So those ones actually do better with PRP because it's an area poorly vascularized, so the platelets haven't get there enough. So I'm providing platelets in that area.
Right. How often are you seeing like a bursa issue with the Achilles tendon?
It's often, yeah, exactly, because it's at that insertion down in with the bone.
Okay. When we, when things become so bad with the plantar fascia, there's treatments that are offered, plantar fasciotomy. Is there benefit to doing that? Actually cutting the plantar fascia? Or are we, is that something that is last case scenario?
But it's last case scenario. What is funny, I was looking because some of these modalities that we tried are out of pocket, the PRP shockwave, and some patient they don't understand the need, and then they go to the surgeon, and I said totally that's fine. The surgeon sent it back to us because even though there is a procedure, and I have it here on this article, there is a release basically for the plantar fascia. The outcomes are not very good. So the surgeon really don't want to do that. Okay, so it's not very often done.
So, and the reason why I think that they tend to stay away from that, the plantar fascia is a stabilizing structure for the foot, right? There's a mechanism called the windlass mechanism. And basically when we walk, the plantar fascia absorbs the load of walking. But then when we go into big toe extension, the plantar fascia becomes rigid to help maintain the arch of the foot. So when we lose that plantar fascia, now we're just, we're continuing to maybe put too much stress through now the bony portion of the foot. The muscles are taking on too much stress. So in the short term, it might feel better, but in the long term,
the mechanics, like the recoil is not there, is what you are.
It's not there, right? So in the long term, these might only be successful if the rehab is extremely delicate, and we're really looking at people to to establish better hip control, strengthening through the muscles, the the rotator muscles of the hip, the glute med, to help give the foot some stability. So when we have an athlete who's coming in with either Achilles or plantar fascia pain, what does the return to sport look like?
That's a very good question, and everyone come in a different severity. So usually younger are better outcomes. We're talking it could be easily 2 weeks to 4 weeks. Older, it might take easily 2 months, okay, to get to an active impact activity. When they come in severe pain, I have to put them on a boot, okay? It's not something that I like to do for prolonged times, but basically we're treating pain first. And then we start treating just the mechanics as they tolerate. So to your question, young athletes that get plantar fascia, usually those are my tennis player and runners. It might take about 2 weeks to calm down that pain. We can still do cardio in different ways. We can do the bike, elliptical, and then maybe if they can tolerate a little bit of jogging, very light impact, short distance, and not high intensity.
Yeah, I think that it's trying to return that tissue to full capacity, right? So pain is always going to pain reduction is going to precede tissue capacity, right? So like the pain levels are going to be reduced. People are going to feel like they can return to their sport, but oftentimes it might be too quick because the tissue hasn't met that capacity of the sport yet. So that's where you mentioned eccentric training, right? That's super important because tendons really feel like they are stabilizing under load. So when we're doing return to sport, when we're trying to heal these tissues, it's important that we really put an emphasis on eccentrically loading those tendons to help them feel like they're creating that load for the tissue, right? That's when they feel strong. That's when that musculotendinous junction feels like it's actually supporting the structure. So, once again, that's extremely important. I wanted to mention first, when you see a young athlete, how do you delineate between plantar fascia and like a severs?
Okay, so the severs is more when the growth plates are open. So I don't see plantar fascia on kids that have the growth plates open. It's not because their trauma have been being long enough. This when we get 20s maybe, and even older, but very young kids, we don't see that.
Yeah. So
we see more the inflammatory component, not the chronic component. And actually, just to make a point, I was reading, and the N-itis is inflammation, but we're calling plantar fasciitis, and we're telling like, hey, this is not an inflammatory process. It's true. It's a mislabel, even though we call plantar fasciitis is a chronicity, and we, instead of tendinitis, it should be a tendinosis that is more the chronic component.
Right. So that's just tissue that's been taking on too much stress for a long period of time. When we see like a tendinitis, that's more of like an acute inflammation of that tendon. That was great, man. I think we covered a lot. I think that people will definitely have a better understanding of how these issues can be treated. I think the goal here for plantar fascia, for Achilles tendinopathy, it's restoring capacity so that pain doesn't come back. So, restoring load-bearing capacity, understanding how to create more connection to that tissue. That can be through hip, it can be through foot strengthening. So all those things, come into play when we're looking at, recovering from these irritations.
And then there is a way to shorten. You can wait until these go away in a year, or we can assist you and shorten the
For sure.
that pain.
Well, all right, man, that was great. I appreciate your time. And then, yeah, I'm sure we'll do a few more of these coming up here soon. Thank you.
No problem. No, okay, so perfect. As simple as here.
Yeah.
Okay, I think we talk about, so when you see that I forget certain things or a concept, you ship in and I do the other way and stuff, so we can solve.
You think it's good? You like?
Yeah. Again, it forced me to read, so I read